The concept for this product came from a Finnish doctor named Dr. Tapani Luukainen, who, in collaboration with the ICCR, the International Committee for Contraception Research of the Population Council, advanced the development of this product. So the Population Council is the organization that really deserves the credit for bringing this product to the market, to having the foresight of the potential impact for the product, to securing the funding, including funding from USAID, to support the development, and then to ensure that the product was approved by the Finnish regulatory agency first, and then the United States FDA. And it was from that point forward that we've been able to advance, albeit 30 years later, to the point we are now, where the product is becoming more widely available.
The Population Council's involvement in long-acting hormonal contraception came from the vision of the Pop Council founder, John D. Rockefeller III. In 1956, Rockefeller knew that the oral contraceptive pill was on the cusp of being approved in the United States, and it would be approved in 1960. But Rockefeller had the vision to understand that it wouldn't be enough and that more methods would be needed. And that's why in 1956, he founded the Center for Biomedical Research, which began researching and developing long-acting reversible methods of contraception, including the contraceptive implant, including the copper IUD, and crucially, including the hormonal intrauterine system. And the Pop Council, through the International Committee for Contraception Research, which was founded in 1970 by Sheldon Siegel, who was the director of the Center for Biomedical Research at the Council, was the engine for the research and development of the hormonal IUS, the original one, and took it through the formulation development, preclinical development, and then the clinical development, and ultimately the regulatory approvals.
And then later on, the Medicines 360 product came along because of the price barrier that we were facing, and as an attempt to have a competitor product that would bring the price down. It's really that driver of generic-like products. It's not really a true generic, but it's an alternative product that's very similar, that helped the price issues and the price competition, which was so critical to getting to the point that we're at today.
I'm excited to be able to advance, women's health, women's actually and children's health, especially given that I'm based in, and all my life I've actually based in low and middle income countries, and where we see how the need is in these settings and how preventable deaths could be avoided, and of course family planning being a big part of how we can be able to reduce this unnecessary maternal mortality. And of course, when you have any additional products or methods that are available to the biggest proportion of women possible, the better for everyone, for them and their children and their families. I want to appreciate and acknowledge that it has been available in the private sector in many of these countries, but the cost has been really beyond the reach of the majority of potential users, and especially those who seek services through the public sector. Cost really has been one of the bigger hindrances.
I think the key and the critical obstacle for full global access has been price. I think once the price came into a range of reality through the tremendous and the coordinated efforts of many, the method started getting traction, particularly with donors, in a way that enabled the broader introductory plans to materialize. And getting products into the product catalog was also a key milestone, and that was an important enabler, I think, for major donors like USAID and UNFPA to enable them to procure the product, which was critical.
The biggest obstacle has been around money. Unit price has historically been the primary barrier to offering this product. Now that we have products that are available at lower prices, there's still a hurdle of getting full introduction plans funded and coordination down to the site levels in countries who've decided to introduce this method.
I think another important obstacle has been the perception of many that this product wouldn't be appealing to women in lower and middle income countries, in large part due to the bleeding changes and particularly the potential for marked reduction in bleeding. It seemed to me that we weren't giving women enough autonomy to make that decision for themselves. One of the really important studies that was done about a decade ago by Dr. David Hubacher at FHI 360 was very important in showing that when women had appropriate counseling and they had access to a product, about 16% of those women in his study actually chose the hormonal IUD.
I compare the SRH space with the HIV space, and I see we've not been very good at advocacy. I mean, if you look at what has happened in the HIV arena of the last couple of decades, 4 decades or so, since the first cases of HIV, I think we've seen a tremendous improvement in terms of access. So perhaps it's also asking ourselves, what are we not doing right? What could we do differently?
There's a real lack of awareness about this method in most countries where we work, and so demand creation efforts need to be well coordinated with service delivery prep, including provider training.
All new methods need time to get integrated into a health system, to train providers, and most importantly, for people to become comfortable with the new method and to come to accept it. And contraception is such a personal and social choice. The second challenge to new methods getting introduced and widely available is the great conundrum of cost and access. And that conundrum is that in order to have a low cost, you need a very high demand and a predictable demand. And in order to have a high demand and predictable demand, you need a low cost. And so it's the community has worked together over time to try to address these cost issues and try to balance out and address the conundrum of new products and public health products. And the last element is that the hormonal IUS is a provider-dependent method, and that's both to insert and to remove. It's very important that it be done very well. And so that kind of training and ongoing training and so on takes a while to get into and really into the systems and the health systems, the medical schools and the OBGYN training protocols and things like that. I think the first milestone that we shouldn't forget in something like this is the vision it took to undertake a program that would take 5, 10, 15, 20 years to develop a method that's a long-acting method.
I think I'm most impressed how there was has been a real coming together of multiple partners for what I think has been a successful collaboration across donors, manufacturers, and across research, service delivery, and commodity partners. So this organized group really signaled to manufacturers and to countries that introducing into low and middle income contexts might be feasible.
I think the proudest I've seen is having some governments actually procure the method through the regular procurement processes. I think for me, when I saw a couple of countries, Kenya included, I think Zambia too, having done that, I think that's where I felt really this has been one of my proudest moments. To see that. Of course, I'm also appreciative of the fact that manufacturers and the farmer that we've been allowed probably less expensive part of that, especially with the patent and all that, making sure that there are others that the pricing is really more acceptable and appealing to countries that have a lot of things that they have to balance against. I also don't want to forget that the ICA Foundation, I really want to acknowledge and be appreciative of the role they have played in making sure that the free commodity, LNDIS as we call it, that has actually helped us to be able to demonstrate that this is a method that is workable in the public sector. But obviously, for me, seeing now governments buying through their whatever procurement channels and making sure that it is, through the whole supply chain is getting to where it is needed, coming up with costed introduction plans that again factor in this, I think has been one tremendous achievement that we should all be proud of in the entire community.
I was also very impressed with when we developed the pilots across multiple projects and with multiple donor funding, that they used identical indicators. That was very intentional. It was really now feasible to show continuation and acceptability data across multiple countries and really amplify the feedback women were giving us about the hormonal IUD. And then, of course, I think I'm most impressed with the work to get product pricing down to a range that's feasible for more countries and getting it into the major donor catalogs.
I think so that the most important milestone in the hormonal IUD is it is expanded. It is expanded in low and middle income countries. It is expanded in sub-Saharan African countries. It is expanded in Asia. It is little expanded in Latin America, except for Mexico and for Argentina. And in Brazil is growing now. But I am proud to be a friend of Tapani Lukainen, the inventor of Mirena, and he passed away some years ago. And I am proud to work actively in the introduction of the levonorgestrel 52 milligram in Brazil.
I've been around since the 80s and on the early studies on this method and watched the evolution of its development as well as its approval by the FDA in Finland, where its first approval was achieved. And I think from the very early times, from the first time I saw this method and heard about it, I found it extremely exciting. And I think that the developer, Dr. Tapani Lukainen, who was a dear friend of mine, was such a strong advocate that I just wish that he had lived to see this point where this product is widely available.
You know that we distribute for 22 clinics more or less 10,000 levonorgestrel 52 milligram per year, and that we receive from the International Contraceptive Access Foundation based in Turku in Finland. And we insert in the Campinas clinic more or less 4,000 levonorgestrel 52 milligram per year. And obviously these figures indicate that we are avoid abortion, we are avoid unplanned pregnancy, we are avoid hysterectomy in the case of heavy menstrual bleeding. This is I am proud.
It's a life-saving tool.
Women everywhere should have access to such a safe and efficacious method.
To me, equitable access means providing women in lower and middle income countries the same opportunity to try this method and to decide for themselves whether it works for them.